was really, I don't. Is there a laser at the end? But yeah, so, I give quite a few lectures and I'm invited quite a bit, but this is one of the most stressful ones because I'm talking to a group of people that are really world experts in all the areas of urology here. And so what do you tell people that know everything? It's a little bit challenging. So I thought I would just, give a potpourri of some of the new things that I think are interesting to know and maybe interesting for our patients, and maybe take a short glimpse as to what's coming. Is there, for the younger people here, there's still a huge amount of opportunities in prostate cancer. We haven't come close to solving everything we'd like to solve. And for anybody who comes to Montreal and wants to visit, we're very proud of a state of the art. It almost looks American, our new hospital, where it actually is respectful for in terms of, this is what about $4.5 billion can pay you as a center. So it's actually the largest square footage building in the province. It's larger than Placerville Marine square footage. And that's because all the rooms are single rooms. It's people don't want to leave when they get hospitalized because they've got floor to ceiling windows on Old Montreal, but it's great. And our research center is the building just next to the hospital where we have our own cyclotron and can produce everything we need. So all the wet labs and phase 1 unit is there. So that took 25 years to build. So politics in Quebec is pretty tough. So these are the disclosures. I've worked with almost every company in prostate cancer as a consultant, and especially in research. So I was going to touch a little bit on non-metastatic prostate cancer. So it's not what I focus on a lot in research, but we did do some work, and I wasn't involved in this paper, but I think it's interesting. It's a relatively recent publication, and it's quite interesting. It's coming out of the group in Sweden, and they looked at 4 years of screening with PSA and MRI, and it's an impressive 13,000 men that had PSAs of over 1.8 and had repeat screening and systematic or MRI targeted biopsies. And I think it's a worthwhile read. I won't go to all the details, but the bottom line is if you omit biopsy and MRI, you significantly reduce the risk of insignificant cancers by about 50%. And the risk of not biopsying all patients is obviously to miss something that would be important, but that was very, very low risk of actually missing a lethal or potentially lethal prostate cancer. We were very heavily involved in Canada on radicals, looking at salvage plus or minus ADT. And I think you already know the first publication was really addressing whether salvage was non-inferior to adjuvant radiation therapy in patients post-operative that were at risk of recurrence. I think that is now pretty much shut, that the role of adjuvant, immediate adjuvant after surgery is pretty much eliminated. You can wait for PSA to rise because there was no difference in metastasis-free survival. But when we say wait, it's above 0.1, not waiting till about 0.8 or 0.9. So above, if you go around 0.1 versus immediate adjuvant, there was no difference in outcome. But the other question in radicals, and this is a multi-thousand patient study that lasted many, many years, is how much ADT do you need, if any? So these two publications came out in the same edition in Lancet, looking at 6 months versus no ADT. And to many of us, that was a surprise that there was no difference. There was no significant difference between giving ADT or no ADT with salvage radiation therapy. And the duration between 6 and 24, because the way it was done, it was supposed to be a 3-way randomization, no ADT, 6 months or 24, but it wasn't palatable. So early in the study, we gave the option to the investigators. You can have the 3-way, or you can choose 0 to 6 because you felt the patient wasn't at such high risk. Or if you really felt ADT was necessary, then you could be randomized to 6 or 24. The other publication was looking at the difference between 6 and 24. And surprisingly, 24 came out to be better than 6. So conclusion is, if you're going to need ADT because you're really high risk, you've got really high risk features, you're probably going to have to give more than 6 months to make it. And then this just came out a couple of weeks ago in 2025, looking at a meta-analysis of all the studies using ADT and salvage radiation therapy. And obviously Radicals was the largest study, but when you combine it with multiple other studies, it turns out that ADT does look like it helps in metastases-free survival in patients that are getting salvage. So it's a little bit contradictory with Radicals, which is a large study, but not large enough to show a difference. But overall, it looks like you are getting some benefit, whether it's short course hormone therapy or long.
Fred, if you go back once, I would just make it more interactive. There's a reasonable trend. The events are very low,
yeah,
but the trend is towards a benefit, even in a subgroup with low events.
Exactly.
Right. So it's probably just underpowered.
Yeah. But this is the largest study, so yeah, it's underpowered because the events are, like you say,
it's also
low.
A subgroup analysis that was not necessarily pre-planned. Right. So
right. And the reality is, when we started Radicals, conventional imaging was the only imaging you can get to determine metastases. But things have shifted where you might intervene earlier. And so some of these metastases that leads to the metastases-free survival could actually be castration-resistant metastatic disease. Because if your PSA is rising too quickly, you might have started ADT. And so you're delaying metastases. And so it became more and more complicated, and that's why we had to just put an end to the study. Money actually ran out because we would have loved to continue until overall survival, but the event rates are really, really low. So these patients are at low risk, even if they're high risk locally. For prostate cancer specific survival, you do see a trend that adding ADT looks like it improves prostate cancer survival, and the meta-analysis in Salvage overall survival is less convincing, but it's going towards possibly an advantage in overall survival. As Martin said, the event rates are pretty low, but if there's any benefit, the bottom line is it would be confined to higher pre-RT prostate-specific antigens. So if you do things right and you intervene early, you probably don't need a lot of ADT. But if you miss the boat and you refer the patient for a PSA of 0.5, 0.9, God forbid, over 1, well, you're not going to get away with radiation therapy alone. So the idea here is, if you want to minimize the exposure, you probably need to intervene early. This is a publication that came out October 2nd. So, and this is purely Canadian. This is the preamble to the Patron study. So Canada was probably one of the only countries who could do this. So this study was really to address the issue whether PSMA changes outcome. We know that PSMA finds disease, right? If you do a PSMA in patients with rising PSA after surgery, you're going to find something. But does finding something and acting on it make a difference? So here, patients were actually randomized to getting a PSMA or not. Americans could not do that study. Europe could not do that study. We actually randomized patients who had biochemical failure after surgery to getting a PSMA or not. And the ones who didn't get the PSMA got what was planned, salvage radiation therapy with or without hormone therapy. But the ones who got the PSMA, if we saw something beyond the local region, they were treated locally plus whatever you captured. And as you would expect, 50% of patients who got the PSMA had something outside of the area of interest. And by acting on it, we saw better failure-free survival, which it's a relatively small study. It's not a huge study, but it made it into JAMA Oncology because it's a proof of principle that I think is interesting in terms of failure-free survival, treatment-free survival, and eugonadal failure-free survival was in favor of acting on something if you did a PSMA. And the patron study is a multi-million-dollar grant that we got, and now it's completely recruited. So now we've got a large phase 3 study, randomized PSMA or not, to address the question. And I think Canada is uniquely poised to answer that question. That's, when we go to Martin and I sit on the APCCC, and the train has passed. PSMA is here to stay. We don't need to look and see if it's worth doing anymore. It's just, it's too late. But in Canada, we have this still window of opportunity to actually do this. And François Bénard here is very. If I switch gears to mHSPC, so some of you might have been at ESMO last year. This is one of the arms from Stampede, because there's a lot of excitement around metformin. And metformin making a difference. We did the Canadian study of metformin in active surveillance, and we didn't see really any difference by adding metformin in patients on active surveillance. But the question was asked in metastatic hormone-sensitive disease whether metformin would make a difference. Bottom line, it doesn't. So in metastatic disease, it didn't make a difference in overall survival, but that's a really high bar. Anything we do in overall survival today is a really high bar, and I don't think metformin is the most active on the androgen receptor. So there was really not much difference, but still, you've got 5.5 months difference in overall survival, but it didn't reach statistical significance. Again, even though it's almost 2,000 patients, it's still not enough with something, but we see this slight trend. But there was other endpoints that are important, and this was pre-planned to look at other metabolic endpoints. So weight gain from baseline was significantly reduced. Glucose change from baseline, HbA1c, cholesterol, LDL, these were all in favor of patients getting metformin. So could this help in reducing metabolic syndrome and cardiovascular risk? Something to think about. So I wouldn't recommend routine metformin, but this is a randomized study, long-term follow-up. There's something going on that's interesting. I don't know the details of whether they actually went back, educated each of the deaths to being related or not, but obviously the death rate is relatively low. I mean, you've got the median is more than 5 years in patients with mHSPC, but it's something that I'm sure they're going to look at, but it hasn't been published yet. So, yeah, sorry.
Did they look if there was any more benefit with some of the ARPIs, for example? Like if they noticed if there was more benefit in some of the ARPIs, like did they see more benefit, let's say, with abiraterone versus patients than docetaxel, or no?
That's a really interesting point. Would that diminish the risks? I don't know. I'll ask Silky. They've gone to that extent. I mean, the thing with Stampede is it's a huge trial on an extremely low budget. So there are limitations, and we've exhausted their statistician. He actually left, because you can ask multiple questions, and it's very pragmatic with minimal amount of imaging and all the rest, because these are not industry trials. So they have a wealth of information. I think they're probably going to try to look at that. But in Stampede, it's predominantly abiraterone that they use. So it will be hard to compare with others because that was a really predominant abiraterone and docetaxel. Canada was supposed to co-lead Stampede, but we won't go back there, right, Martin? We got turned down when they came and approached us to co-lead Stampede because the executive felt at COAG and NCIC that they would take up too much energy. Anyways, PSA and hormone sensitivities. Just a few words. I won't go back on the trials. You all know the trials, but in ARASENS, looking at ADT plus docetaxel and darolutamide, time to PSA progression was clearly better when you added darolutamide to docetaxel. So this was a design of ADT and docetaxel as the best control arm that we had at the time we designed ARASENS. And we wanted to ask the question whether adding an ARPI, and here was darolutamide, would make a difference. And it did make a difference in overall survival. But looking at PSA progression, you see ADT and docetaxel 22 months, not reached when you added darolutamide. But we actually went back and looked at the high volume patients. And at 4 years, 65% of high volume patients had not yet progressed PSA-wise, compared to only 27% in the control arm with ADT and docetaxel. But interestingly, the low volume patient, where many of us probably don't even consider adding docetaxel to the base of ADT and ARPI, we're up to 92% with no PSA progression in 4 years. Does this answer the question that all low volumes should get it? Absolutely not. But it might address one of the issues of, can we stop therapy at one point? This is, I think, one of the low-hanging carrots to an aggressive early approach, is the hope that maybe after some time, you can actually stop ADT and the ARPI and leave patients alone. On the flip side, if you were getting ADT and docetaxel alone, here it was 33 months to PSA progression, and only 36% of patients were not progressing PSA. So where I want Martin to help is, why are these patients, what can we do more for these 35% of patients that are progressing even though they're getting triplet? What is driving the progression in the high volume patient? Can we do better than the triplet that we offered in this? Because 35% of patients are still progressing, even though we're giving them what we consider for now the most aggressive therapy. Can we do better than a 35% failure rate in these high volume patients that have clones that are clearly resistant in some form to hormonal therapy and to chemotherapy? And that's where biology needs to play a better role in how we actually decide to treat those patients. So PSA response, and this has been a little bit of an obsession of mine, until we find a better biomarker, it's probably the best we have for prognostic response. So undetectable PSA was 67% of patients with the triplet versus 28 with the doublet. And you see the PSA time to PSA progression was much better if you were undetectable. And undetectable was less than 0.2 versus simply being detectable above 0.2. A huge difference, 77% difference. And importantly, overall survival was much better if you reach undetectable versus simply not reaching undetectable. And if you didn't get to below 0.2, the median survival was only 33 months. So the bottom line is, the way you follow patients should be personalized based on your best PSA response. You can't follow a patient every 6 months who didn't get to below 0.2. They're going to fall apart between 2 visits. They're dying in 33 months. If you look at the high volume, we're up to 62% of undetectable PSA. And they do well. At 5 years, the majority are still alive. But look at the ones who don't get below 0.2. The survival is only 28.9 months as a median, even though they got triplet. So again, how you follow those patients should really depend on how low the PSA gets. In the low volume, we're up to about 84% get to undetectable. And here, almost no patients are dying at 5 years. They're likely dying of other causes. So maybe this is an opportunity, like I said. Some patients actually stop therapy altogether. This is where we'd like to go. I don't think anybody wants to keep a patient castrate for the rest of their life if there's some way of stopping castration. You know, Larry led the intermittent trials. And this is a form of intermittent. Why not stop? We used to do it with ADT alone. If we can do much better than ADT alone, I think we can consider doing a type of intermittent. But I think we might actually cure some patients with a very aggressive upfront approach. I don't know if that 4-letter word is inattainable as we get better in how we treat patients. And again, this is for Martin and his team. Why are patients getting to undetectable and still dying? There is something driving the cancer that PSA doesn't pick up. They are getting really good responses, but still about 20-25% of patients are dying within 5 years. So what is the driver? I think the guns might answer some of those questions that might not be AR dependent and leading to death in these patients that do get undetectable PSA. And this is one of the concerns I have with the present Canadian trial that I'm supportive of. But when you're saying intensify only if you don't get below 0.2 by adding chemo or whatever, there are some patients that get to below 0.2 but are still dying. So, we probably have to figure that out. Error note, just a couple of words. This was a follow-up to ARASENS that already proved that darolutamide prolonged survival. So we purposely had a small window of opportunity, so we didn't design an overall survival trial that would have taken at least a couple of years longer and a lot more patients. So this is 669 patients randomized 2-to-1 to darolutamide. But we had to do this in countries that didn't have access to ARPIs in the hormone-sensitive setting. And that was the reality even in Canada when we started the study. And then COVID forced or encouraged the payers to pay for ARPIs in the hormone sensitive. So it was underpowered and too short for overall survival. But we did learn a lot about PSA again in patients on ARPIs. This adds to the wealth of knowledge of the importance of PSA declines. So 63% of patients did reach undetectable below 0.2. You can argue if that's really undetectable. I don't deny that truly undetectable should be even lower than 0.02. But 63% got there. But if you don't get to below 0.2, again, 17 months to RPFS, 11 months to castration-resistant disease, and 14 months to PSA progression. So these patients really are going to progress much faster than patients who get to below 0.2. Again, patients get to below 0.2, and we're still becoming castration-resistant in less than 3 years in about 20% of patients. Who are those low-volume patients that we probably need to do more than an ARPI plus ADT? And we did have the opportunity in error note to actually look at ultra-sensitive PSA. And here we get 43% getting to below 0.02 that we use in surgery and here, if you do get to below 0.02, almost nobody fails or progresses 3 years. So I think that is the holy grail. But for most patients with an intact prostate that was never treated, it's a little bit high bar. So should we operate these patients? Should we give them radiation therapy if they don't get to below 0.2 or don't get to 0.02? That's an unanswered question. But I think we probably need to slowly get to this truly undetectable level. And we're just in the process of publishing this in a very high impact journal on the quality of life of treating these patients with this doublet, because we were one of the few that actually invested a lot of energy in terms of looking at quality of life, and we were able to link quality of life with PSA decline. Now, if we switch gears, so I have 2 hours, right? Martin's going to fall asleep way before that. So in mCRPC, just a couple of words on the most recent publication. This is in TALAPRO 2. So it's the concept of combining an ARPI with a PARP inhibitor in first-line mCRPC. So, TALAPRO 2, PROPEL, we're an all-comer population, and I won't argue that probably the only people that will benefit from that combination are patients with mutations. So TALAPRO 2 has the largest cohort, 400 patients with mutations, and I'll just concentrate a couple of slides on that group of patients and the importance of considering a more aggressive approach than ARPI alone in patients with known HRR deficiency. So the primary endpoint of RPFS, just look at how quickly they progress on enzalutamide if you have a mutation. Within 12.3 months, you have a radiographic progression on enzalutamide alone in that group of patients. That's really fast radiographic progression, and that goes up to over 30 months when you add a PARP inhibitor. Now you're going to ask me, is it all driven by BRCA mutation? Right? Because HRR includes BRCA, so we did look at that. And in the BRCA patients, look at how quickly they progress. In 11 months, they're progressing, and it's not even reached. So what you actually are doing is by adding a PARP inhibitor in a BRCA mutated patient, you basically bring them up to a non-BRCA mutated population. You don't even reach the median at 4.5, 5 years. You haven't even reached, you actually, but this is a small group, you're actually looking like you're doing better than a non-mutated patient by adding a PARP inhibitor in a BRCA mutation. So if you know they have a BRCA mutation, you really have to act on it as early as possible. But what is interesting is even if you don't have a BRCA mutation, but you have some other mutation, PALB2, check. There's a multitude of other mutations, but excluding BRCA, you still have significant advantage. And here you're getting about an 8-month improvement in RPF. Objective response significantly increases also. You go from 38% of objective measurable response up to 69%. And you go from complete response of 17% with Enza alone up to 44% in a mutated patient. I think that's pretty impressive that you can hope for those kind of complete responses in these metastatic CRPC. So the important question is, does it matter for overall survival? But look at this. This is a 14-month improvement in overall survival by adding a PARP inhibitor to patients with a HRR mutation. 14 months. That's triple what we see with all the agents we presently use in mCRPC. So this is a 38% reduction in the risk of death. And I think this is to strongly consider, especially that the control arm is not a placebo. What was the control arm for the Enza and Abby studies? It was a pure placebo to show a 4-month improvement in overall survival. Here you're getting a 14-month improvement against the best standard of care is an ARPI in mCRPC. That's pretty impressive. No switch. These are patients who were not exposed to a prior ARPI. So you're going to tell me this is a shrinking population, and you're absolutely right. But in Europe and in many other countries, you're allowed to do this regimen even after an ARPI. So that data in the real world is starting to accumulate. So we're working with Brazil, Japan, and Europe. The approval for this combination and the olaparib-abi combination is in anybody who doesn't require chemotherapy. So it leaves it open to be able to study this. And again, coming back to overall survival, if you have a BRCA mutation with enzalutamide, you're only living 28 months on enzalutamide alone. The importance of knowing whether you have it, and you don't even reach the median survival at 5 years if you combine it. This is for mCRPC. And in the non-BRCA mutated patients, the numbers start getting small, so the statistics are not there, but it's still a 10-month difference in overall survival against an active control. So a few words on PSMA and radioligand therapy, because this is where I think there's a huge amount of excitement, maybe a little bit like robotics, a little too much excitement, and where you're hoping for too much, and so the disappointment rate can be a little bit higher if your expectations. So, there is undeniable that lutetium has changed our practice. But I think a lot of us were a little bit disappointed that it wasn't earth-shattering differences in overall survival, right? There was a 4-month improvement. 4 months is always what we see in mCRPC. And this is 4 months against basically palliative care when you give lutetium post-ARPI and post-taxane. So it's a little bit hard for such an expensive drug to just say, let's just give 6 cycles of lutetium and hope for the best. So we published this last year from Vision. And you can use an $8 biomarker to help determine whether the patient is benefiting or not. Just look at the value of PSA after 2 cycles of lutetium. If your PSA is not going down, that's the yellow line, your median time to progression is less than 6 months for radiographic progression, and your median survival is less than 10 months. A little hard to give a drug that takes 9 months to give in a patient who's going to live only 10 months, right? So after 2 cycles, if you're not seeing a PSA response, consider what other options are available and maybe think of changing therapy. the bottom line. Whereas if you get a 90% decline after 2 cycles, here you're not even reaching the median in overall survival. So you've just identified a patient that is really worth continuing the lutetium. We need these kind of, our healthcare system can't just afford, and the patients can't just afford staying on using a drug that isn't going to make it. We need to put them on a clinical trial. If they haven't gotten cabazitaxel, think of Cabazi. But we need to do something else if they're not responding, because these patients, unfortunately, have a very short window of opportunity. So it's nice to know after about 3 months whether or not they're getting it back. So the other trial in the chemo-naive situation, so these are patients post-ARPI, was published last year, presented at ESMO as a presidential. And we had a lot of hope that this would make a huge difference in the pre-chemo setting by giving lutetium prior to chemotherapy. And yes, in terms of RPFS, clearly there's an advantage to an ARPI switch. But in overall survival, it was a little bit disappointing that we didn't see any significant difference in overall survival when you gave an ARPI switch versus lutetium. Obviously, there was crossover. About 85% of patients, when they progressed, they got access to lutetium. But the early lutetium didn't seem to make a big difference. But you still got about 50% measurable response with lutetium. So there is something clearly in terms of PSA response and radio and measurable response, which is better than what we see with chemotherapy post-ARPI. So there is something there. We just need to refine who's benefiting and how to use this. One of the trials that's going to be presented at ESMO next week is our Canadian-led trial that Kim, François Bernard, and myself are leading, that we completed very, very quickly, 200 patients randomized to lutetium against docetaxel, which is probably the question that we have to ask after an ARPI. And so the first part of the analysis is going to be presented at ESMO. So I can't say much more about that. But there's a lot more translational work that we hope is going to help in deciding if it's better to go to chemo or an RLT approach post-ARP. Just a few words on another trial with a radioligand, that's radium-223. It's an old radioligand. Hasn't generated a huge amount of excitement because it's really limited to the bone, doesn't change PSA. And so it's questionable for many people who's getting an advantage. So the question here was, if you have a patient mCRPC starting enzalutamide, whether adding radium or not makes a difference to enzalutamide. It's a small study, cooperative group. Canada co-led the study with the ORTC. And at the beginning of the study, there was no obligation to use a bone-targeted therapy. So we have about 120 patients where it was optional. And it was about 50% of patients were on a bone-targeted therapy and 50% were not. The primary endpoint was RPFS, and this was radiographic progression was reduced by 31% in patients getting radium on top of enzalutamide compared to enzalutamide alone. This was strongly statistically significant and was presented last year and now published in Annals of Oncology. Annals of Oncology, by the way, now has a higher impact factor than Lancet Oncology or JAMA Oncology or JCO. So it's taken off. Europe has taken off in terms of journals. So if you want to publish high now, think of Annals of Oncology. Overall survival, 31% reduction in the risk of death. But we have to wait for the maturity. We just got the data last week for overall survival. That'll be published and presented. Let's just say the data holds. But you didn't hear it from me. Oh, shit. No, anyways. Well, those survival curves, you would expect it would hold up and we wouldn't see anything drastic. But we have to wait because at the beginning of the study, there is this weird situation where the curves are inverted. So this is a non-proportional hazards that the statistician would say you can't claim survival, even though the statistics would suggest it. You have to wait for the complete results because of those crossing of the curves at the beginning where there were a lot of fractures. Now, what was presented at this year's ASCO was looking at ALP response and PSA response, which adding radium surprisingly made a big difference to enzalutamide alone. The speed at which you reached a 90% decline in PSA in mCRPC and the percentage of patients that actually reached that was higher by adding radium. The speed at which it declined was 5.6 months with the combination versus 22 months with enza alone. So something's going on. We're still trying to understand. Now, something I presented this year at EAU was an interest of mine, some would say an obsession of mine, about the value of bone-targeted therapy. And here you see the fracture rates before there was the obligation to use a bone-targeted therapy. Before the obligation, the fracture rate was 36.5%. It actually went up to 53% if you were getting radium and enzalutamide without a bone-targeted therapy. That fracture rate increases when you combine radium to anything that you use. After the urgent safety letter, 5%, and the difference in radium or not almost disappeared. But my interest was, does bone-targeted therapy do more than reduce the fracture rate? Does it really have maybe some anti-cancer properties? So we did this analysis based on the small number of 120 patients where we had really long follow-up. So the way you can do a clinical trial is you do a huge clinical trial, you get results early, or you do a small study with a long follow-up. So here we had a really long follow-up because these are the patients who came into the study really early. But looking at the use of bone protective agent, RPFS was 14 months longer between those that got a bone-targeted therapy versus those that didn't. And if you look at the 4 different cohorts, if you had radium, enzalutamide, and a bone protective agent, your RPFS was 28.9 months versus 12.9 months if you got enzalutamide alone. It's a small cohort, it's hypothesis generating, but I think the difference is quite striking. And the hazard ratios are below 1 in the RPFS. And the biggest surprise was actually this. This I was hassling the statistician at EORTC to, I was hoping to see maybe a slight difference, but I didn't expect 17-month difference in overall survival. Hazard ratios again below 1, 44% reduction in the risk of death. And so there was a big difference in overall survival in those patients who got a bone protective agent. The quadruple therapy, enza, ADT, radium, and a bone protective agent, 71-month survival versus 22.8 months with enza alone.
I think European guidelines recommend using a bone protecting agent from the hormonosensitive, while in our Canadian guideline is based on your risk and bone density.
They don't recommend using the high dose in hormone sensitive.
Correct. Yeah. But
they recommend
but I think it's more like a universal use, but not to the high dose of the CRPC one. But our guideline will say you do your bone density, you do your FRAX score, and you give according to. Do you think we should do more of a European approach of universally giving it, regardless, just because
I don't think every patient needs a bone targeted therapy in a hormone sensitive setting. I think you need to figure out who's at risk, and I think we've got good tools. So yeah, and sometimes in some guidelines, it's easier to say use in everybody and not reflect. But I think there's a risk-benefit ratio in everybody. If you really don't need one, I prefer not using it in patients who aren't at risk or at minimal risk. But you need to follow because they can become at risk even if they weren't at baseline. So the role of metastasis-directed therapy in mCRPC. This is a paper that just came out in Lancet Oncology also. This is, again, Canadian-led. And they co-led this with Tamim Niazi. And this was really randomized to getting enzalutamide plus or minus SBRT in oligometastatic CRPC. And even though the study had to close prematurely because we're starting to see less and less mCRPC patients not previously exposed to an ARPI, there's a long enough follow-up that there was a significant difference in radiographic progression-free survival and subsequent treatment of these patients. And that RPFS difference is over 2 years by giving metastasis-directed therapy in oligometastatic CRPC added to the base of enzalutamide. This is the reference came out in September, so I'm showing you stuff that came out just a few weeks ago. And this is the group, the PCS9. So, you know, I've been helping to develop the CRPC guidelines with the help of several people here, and it's becoming more and more difficult because how do you define first-line mCRPC anymore? Right now, you have to always ask, what did they get before becoming mCRPC? And depending on what they got before, the next line should really be appropriate for that patient. And there are at least 5 scenarios of what you could have gotten before becoming mCRPC. And then you have to dictate what you would give after and second line and beyond. So I won't go into, but we added the bone protective agent for mCRPC should be recommended for non-SNAP or zoledron. I'll just end on a couple of notes of things that are coming. PARP inhibitors and mHSPC. So we clearly established for mCRPC, and first report in hormone sensitive was with niraparib that was presented at ASCO. It's an rPFS endpoint, and you see really the ones getting the most benefit are the BRCA mutated patients in terms of radiographic progression-free survival. Overall survival still too early to claim that it's going to change survival, but it should. It should, because we're giving it to patients who are going to become mCRPC relatively early, and they're already on a PARP inhibitor. And in the subgroup analysis, really what's driving the results are the BRCA mutated patients. Obviously, we need to be concerned about giving a PARP inhibitor for 5, 6, 7 years in patients who are going to do well. We're going to end up having maybe a proportion of patients developing second cancers that are not insignificant. So we have to determine how long we should expose these. Talazoparib is going to report on mHSPC probably early next year. Event rates are slower than we expected when we designed the trial, but that's a good thing for patients. AKT inhibitors in hormone-sensitive disease are going to be reported at ESMO next week. So this is really looking at PTEN deficiency in mHSPC and randomizing them to an AKT inhibitor or not, plus the very best standard. So the press release said it was a positive study. We'll get the details next week. And this is going to be a presidential session at ESMO. So these are the results of the PSMA addition study, looking at adding lutetium to the best standard of care in terms of ADT and ARPI. What was nice about this study is that it was agnostic to which ADT and which ARPI. We're not handcuffed to any specific ARPI. And crossover was allowed as soon as they had radiographic progression in the standard of care arm. So you know the press release was the trial is positive in rPFS, and the details are going to come out next week. Scott Tagawa is going to present on behalf of the steering team. And then we're getting a little innovative. You know, we'd all like to maybe not use ADT. This is a phase 3 study looking at patients with biochemical recurrence without any evidence of metastatic disease, but have something on PSMA. And here we're going for SBRT to the metastatic lesions plus or minus lutetium without any ADT to see if we can delay MFS and if we can delay the need for radiation therapy, hormonal therapy. This is a study that's actually ongoing right now. Well, that's why I wouldn't do this outside of clinical trials. You know, the Australians are even doing it pre-radical prostatectomy to see. So these are the issues with RLT, with PARP inhibitors. But I won't go into any detail, but this field has actually exploded in terms of RLT looking earlier, but now there's a whole generation of new RLTs with actinium-based radioligand therapies that we hope, and so far the phase 1s that I'm working on and I'm helping to lead, the results are amazingly interesting. Obviously smaller numbers, but we're going to be going into phase 3. There's a lot beyond lutetium PSMA, like I said, actinium and other compounds. We're working on a PSMA STEAP1 topo inhibitor. that really has multiple targets, and the phase 1 results are really, really impressive. And what's nice about this is that even in PSMA negative lesions, we're getting as good response. And 50% of the patients in the phase 1 study have been post-lutetium, who are getting as good response as those that hadn't been exposed. Can't share more data. Hopefully going to present some of this very soon. There are other targets, looking at CD3 on T cells, where at least the preliminary results look interesting. So stop there. MRI reducing biopsies and diagnosing insignificant cancers. Salvage radiation therapy doesn't always require ADT. And if it does really require it, probably long-term is better. We haven't really looked at the role of ADT and ARPI, which I hope would shrink also the exposure to ADT. Lutetium in mCRPC, possibly soon in mHSPC. PARP inhibitors, the same thing, possibly soon in HSPC. Whether or not we add radium to an ARPI may become an option in the future. The role of metformin thing needs to be kept in the back of our minds in somebody who is at higher risk of metabolic syndrome if we're not following them properly. Darolutamide with or without chemotherapy, now an option. And PSA is really, really useful. For now, it's probably one of our best or the best biomarker we have for prognosis. And there's still a lot of ongoing research for novel targets. Just a quick thank you to in part of the research team that helped make all of this possible. Thanks a lot.